So welcome everyone. Thank you for joining us for our second talk of the year, and we are the Contact Lens Interest Club, and my name is Helen, and I'm one of the Director of Communications of CLIC. So CLIC is a student-run organization that aims to operate educational and experiential learning opportunities for optom students interested in contact lenses. So we provide a platform for contact lens specialists and industry leaders to share their experience, and some of our past events have included guest speakers, hands-on scleral lens workshops, and tours of contact lens manufacturing labs. Hopefully in the winter term, when everything is back in person, we are able to once again organize these activities for you. But this term we will be focusing on delivering speaking events by optometrists and other industry leaders. There is also no membership fee to join our club, so we encourage everyone to follow us on our social media, just so you guys can see what events we have planned in the upcoming months. There will also be gift cards or other prizes to be won at our events, so make sure to follow along. So I will now introduce our speaker for tonight, Dr. Sherman Tung, who will be presenting the basic fundamentals of myopia management, and he will also discuss the new advances in myopia management with technologies and treatments. So Dr. Sherman Tung completed his Doctor of Optometry degree at the Illinois College of Optometry in 2006 and was accepted into a prestigious residency program at Illinois Eye Institute, specializing in ocular disease and primary care. After his residency, he continued to excel by obtaining his fellowship at the American Academy of Optometry and International Academy of Orthokeratology and Myopia Control. Dr. Tung is also involved with the BC Association of Optometrists, where he was elected as the president in 2013. In 2019, he was honored to be named BC Optometrist of the Year, the highest award given to an optometrist who has not only contributed to the advancement of optometry, but has also demonstrated a fervent commitment to serving the community and improving the visual welfare of the public. Dr. Tung currently owns a private practice that specializes in myopia control and vision therapy in the heart of Vancouver, and he enjoys spending time with his twin daughters during his free time. So this talk will be recorded, and make sure you guys stay till the end of the talk because we'll be having a poll for attendance for the draw of 4 $25 gift cards. So now we will welcome Dr. Tung for his presentation.
Thank you, Helen, for the introduction. I hope everyone can hear me. So myopia control is one of those really kind of sexy things that a lot of people want to get into. And I know a lot of students or new grads about to graduate, they want to learn a little bit more about it. How do you manage it? The great thing about myopia management is there's not always one way to treat it. And the other great thing about it is that it's always constantly changing. So there's always something new. Treatments, it's always new. So by the time I go over this presentation, maybe in a couple of months, there might be new studies that's come out. So for now, I'll kind of give you the basics, and then hopefully, if you have any questions, I'll answer them all at the end. Okay. So I'm just going to go to my next slide. Okay. There we go. So just the basic, what is myopia? So that's pretty much, in the normal eye, all the light converges onto the retina, onto the macula, and it gives you a clear image. For a myopic eye, the eyeball is a little bit longer, so all the light converges in front of the retina, creating a kind of blurry image. That's pretty much the fundamental of what myopia is. So why does myopia happen? There's many different factors. One is genetics, and the other one could be environment. So if you spend a lot of time up close, those are things that can create myopia. So the last study that came out, 30% is usually from genetics, and actually 70% is from environment. So why does myopia get worse? One of the reasons is when you wear glasses, it actually makes things worse. So the whole idea is that when you look at a normal pair of glasses, it's usually thinner in the middle and thicker on the sides. So the idea is that the central rays will actually focus right on the retina. But the peripheral of the lens is actually a little bit thicker, so it actually over-focus. When that happens, this is called peripheral hyperopic defocus. This actually sends a signal to the brain and tells, hey, those images are not clear. So the brain will say, okay, make the eyeball longer. And that's why most of the times, whenever you wear a pair of glasses, like normal single vision, it makes, myopia worse and encourage the eyeball to grow even longer. And hence the myopia gets worse and worse and worse and worse. Um, so back to the slide. So yeah, a lot of research has tried, hey, what can we do to actually maybe move those 2 points, the peripheral points, back into the retina? And we'll go over some of those methods later in the presentation. So with myopia, we have different type of myopia. So the ones are usually low is between -1 to -3. Moderate between -3 to -6. And then if you're high myopia, -6, that's when the trouble happens. And we want to keep our patients as low as possible in terms of myopia. So you can see what happens if you increase myopia is that your eyeball will get a little bit longer. And some of the factors with the eye, if your eyeball gets longer, the cataracts risk also increases too. So you can see as a low myopia, it's only about 2 times the risk. But once you go to high myopia, it's almost up to 5 times. And then with glaucoma, so because you're stretching the whole retina, you're also stretching the optic nerve. So low myopia and moderate myopia is pretty similar, about 4 times the risk. If you have low or moderate myopia, but once you hit that high myopia, it's almost 14 times. So that's why whenever we see patients, we always want to try to keep their prescription as low as possible. And for the retinal detachment, you can see low is about 3 times, moderate is about 9 times, and high myopia is 22. So there's a lot of numbers here. Just the whole take-home message is, try to keep it under -6 diopters. The risk of those ocular disease will be decreased. So the whole topic's on ABC. So first thing, the whole topic about axial length. So axial length, what is it? So it's the distance between the front of the eye, the cornea, all the way to the back of the eye. So that's how we measure it. So normally how we measure them, actually, see if I have a slide on that, sorry. I'll go over how to measure them in a second with the axial length. For the age group, infants, this is just a guideline. They're still working on the list because it depends if what type of ethnicity you are. If you're Asian versus Caucasian, eyeball length might be a little bit different. But in general, infants' axial length should be about 20 millimeters. Children between 47 between 21 and 22, and teenagers should be about 22 to 25. And they can see that adults should be about 22 to 23. So we really don't we really want to keep your axial length below 25 or 26 millimeters. So that kind of gives you a ballpark. And also axial length, usually from clinically, when we look at, when we measure axial length, it usually stabilizes between 13 to 16. Usually it goes really, really, really high. It's during between age 7 to about age 11. So that's when I see the axial length increases the most. I guess that's during their growth spurt, and sometimes kind of early stages of puberty. That's also when it also increases quite a bit. So as I mentioned earlier, whenever you get those myopia diseases versus myopic degeneration, so the major risk factors is the axial length is greater than 26 millimeters. So we want to keep it under that. And then the refractive error, we want to be under -6. So I used to do refractive error as one of my key components. Want to keep it under -6. But as more papers and papers are coming out, it shows that axial length is more important than refractive error. And sometimes it's kind of hard because you're treating someone with, ortho K, and the refractive error is like, let's say, close to plano. How do you know it's getting worse or not? It's really hard to tell. So that's why axial length is kind of the gold standard now. when you're measuring or treating myopia that, if it's getting worse or not is to measure the axial length. Like I said, as your eyeball gets longer and longer and longer, macular degeneration, you keep stretching your eyeball. So when you stretch your eyeball, you can, break some of the Brooks membrane. That can happen, and it can get wet macular degeneration also. Posterior staphyloma, again, you're stretching that whole retina. This could be definitely some thinning. And then once you've thin enough, then you get some retinal tears and some detachments. So how do we measure monitor axial length? There's many, well, back then there's many different ways. The one that I use is the Maya Topcon. And this one kind of uses, hold on, did not talk about. There are many different ways to actually measure axial length. One way is that you can actually use a direct tip, kind of like a pachymeter. You kind of tap, and they'll tell you how long the eyeball is. Those equipments are usually about $5,000, but getting consistent data is not consistent at all. So it's not very accurate. So you always want to make sure that it's repeatable, and you also want to make sure that it's accurate. So how we measure it is the Maya, and so it kind of uses interferometer to actually measure how long the eyeball is. So right now, when I got the machine, Maya was the best machine. Um, you guys might hear from Hog Straight, they have one called Myopia. Hog Straight one, they also have the Lens Star, that's what's called. And then they also have one called, sorry, I should have written this down. They also have one from Ocular Master from Oculus. And then they also have one from Nidec. So these ones are very easy. You just kind of put your head in there, and then you just look at a target and it just measures how long the eyeball. It's almost like doing an auto refraction. And it's very repeatable and it's very accurate. So those are the ways that, if you do see a place where they're measuring using, a probe, it's not as accurate anymore. So those are kind of moving forward when you go into a myopia clinic. It's kind of something that's basic. I guess the best example I could give you is like glaucoma. So back then when we graduated a long time ago, we'll treat glaucoma, measuring the eye pressure, checking the visual fields, and look at the optic nerve. And then OCT came, and that's when we can actually measure the tissue. Same thing with axial length. It's the most accurate way, and I don't know how you will do myopia control without measuring the axial length. So it's kind of important nowadays. So B is blue and UV light. So each time I do consults, I get a lot of questions. Hey doc, my kid's doing a lot of Zoom meetings. Can I get some blue light glasses so that my kid won't get myopia? So you hear that a lot. And it's kind of mixed in the literature. Does blue light actually help or it doesn't help? We'll talk a little bit more about that. So indoor lacks UV and violet light. You have too much UV exposure, it's linked to cataract and eye disease. You guys all know that. You cook the tissue. You have too little UV exposure, it's also linked to myopia. So we don't know why, but if you're pre-myopia, you kind of want to spend at least 2 hours outdoors a day, and that's kind of like the recommendation. But nowadays, with all these kids, they spend less time outdoors, they spend more time indoors. So that's why we don't know, UV light, blue light, is it good or is it bad? We have no idea yet. So just want to let you know, there's not enough data to show that actually blue light is, blue light itself does not promote myopia. We don't know. Blue light is found in both electronic devices and outdoors. So in terms of blue light, violet light, for the glasses part, if someone's have eye strain or they have problems sleeping at night, then I will recommend some blue light filter glasses. But in terms of one of my patients says, hey, would it slow down the progression? There's not enough data, so I will say no. So I won't promote it. Um, so usually I'll tell them, if they do a lot of intensive schooling, long periods of work, works in an urban environment, I'll tell them to go outdoors way more. The other thing that, we kind of educate our patients, you guys all know the 20-20-20 rule, but a lot of our patients don't know that. So when you guys are in clinic, just make sure you guys promote this. So for every 20 minutes, spend 20 seconds looking at 20 feet away from your screen. That gives the muscles in your eyes, to relax, to prevent eye strain. Um, there's no study that actually shows that it will slow it down, but I think it's just a good idea to, break up their close-up work. But I'm pretty sure there might be some papers coming out soon of continuous near work may cause myopia. And we always said spend 2 hours outdoors per day. Now, one of the cool things, well, not cool, I tell my patients is that majority of my patients all drive their kids to school. So usually what I tell them to do is like park at least 5 blocks or 10 blocks away from the school and just walk the rest. And then that way they can spend more time with their kids and then they can also spend more time outdoors. I guess in Toronto or area, it could be snowing, so it might be a problem. But in Vancouver, usually we get a lot of rain. So it depends on which part of the country you're in. But one of the tips I tell my parents is park a little bit further and then just walk to school. All right, how are we doing in time? 20 minutes. Okay. So C is for correction and control. Um, so we're gonna go into, what the different treatments are. I'm gonna be talking about the 4 common way that we, correct it and control it. There's gonna be way more coming out, and as I go through each um, method, um, when I've made this presentation, there's already like 3 things that came out that are kind of new already, and I'll go over it with you guys. And that's how fast myopia control is changing with all these new studies. So one of the things that I tell my patients is a lot of them is like, oh, if you treat my patient, it'll be cured, and they'll go back to normal, back to plano. And that talk with parents is like, no, this is kind of permanent. You can't really go backwards. The best analogy I give them is like once you kind of cook an egg, you can't kind of like reverse it back into a raw egg. So it's kind of important to, you know, hold it, the axial left as, keep it as low as possible or the prescription as low as possible. So we can correct the refractive error and we can control, like the word is control or manage its progression. So there are some studies that we can actually control it. So we'll talk a little bit more about that later. So back to, the original slide that we talked about, how to control myopia progression. So, anytime you wear glasses or there's some studies that might show that there's squinting that can cause the eyeball to get elongated. So the whole idea is to get rid of the peripheral hyperopic defocus. And the idea is to place a lens or somehow, we can create the light to be in front of the eye. So then we don't send those signals. So that's the whole idea. So your peripheral vision might be a little bit blurred, but for most kids, they usually look through the center. So it really doesn't affect their overall vision too much. So we want to create the opposite of peripheral hyperopic defocus. We want to create peripheral myopic defocus. So the first option we're going to talk about is orthokeratology, and that's kind of almost 80% of what I do at my clinic. So how does ortho-K work? So you have wear at night and nighttime. It kind of molds the eyeball overnight and changes the shape of the eyeball. So how it works is that overnight when you grow your, actually, let me rephrase that. So overnight, the cells, there's 2 theories. The first theory that was before was you grow this every single night, we grow cells. And how it works is that you try to trick the cells to grow on the sides only in a peripheral circle instead of in the center. So that way you create your eyeball to be more flat and therefore you can change the refraction, make the cornea flatter, and then you can see clearly. But the newer theories nowadays is called intracellular um, fluid exchange. So different cells of, in the central part of your cornea, those cells kind of get dehydrated like a raisin, and then on the peripheral, it kind of gets swells up like a grape. So those cells, so there's no cell redistribution, but more just like redistribution of intracellular fluids. But the whole idea at the end of the day is that you make the cornea flatter, and the center will be focused on the macula, but the peripheral rays will be focused in front of the retina. So before we get started, you know, you have to see if this patient's a good fit. Do they have a high amount of astigmatism? And are they going to be cleaning every single day? Because at the end of the day, you have to make sure that ortho-K is safe for the patient, because that's parents' number one concern. So if they're like a 3-year-old or 4-year-old, usually, we gotta be a little bit aware of that. And if they're 3 years or 4 years with high myopia, there's something wrong. So you gotta make sure that they don't have any like connective tissue problems or anything like that. If they have a high amount of astigmatism, that's also could be a problem, because the lens will be rocking quite a bit. So if you put a spherical lens on a, you know, astigmatic cornea, then it's going to be rocking back and forth, and not going to create a nice mold. But with the newer designs, with all the designs already pre-made, those were harder to fit. But as programs and softwares get better and better, you can actually treat that pretty well. So you can make toric ortho-K lenses, which is kind of exciting. So that didn't really come until like 2 years ago. And if the kid is not going to be cleaning, the parents not going to be involved, I probably won't fit this patient with ortho-K also. The second thing we have to do is we have to do topographies. Of all my equipment that I have, topographer, well, the axial length machine is kind of important, but the topographer is the most important thing, because if you're not taking really accurate topographies, you're not going to create a great lens, and you're going to be just running in circles and circles and circles. So that's why it's so important to take really, really important maps. I'm not sure if you guys know this, Randy Kojima from Precision and Cardinal. He has a really good video on how to take really good topographies with the MedBot. So I highly encourage you guys to kind of watch that. And also topography is important because, how do you know where the lens set the night before? Is it sitting too high, too low, to the left, to the right? The only way you can tell is by a topographer. So you can't look at with it with the slit lamp. And then axial length. So you want to measure how long the eyeball is. Usually the eyeball will grow about 0.1. So usually I tell my patients, if they hit 25 millimeters, I'm not very happy with that. So if they're like 23 or 24, I try to keep them. My goal is always try to keep them under 25 millimeters. If they're already 25 or 26 millimeters, then my goal is to make sure that they don't grow more than 0.1 millimeter a year. Average eyeball growth length is about 0.1 millimeter a year. So I want to make sure that they follow that trend. So that's why majority of the time, I'm following all my myopia control patients every 3 months. If they're growing quicker, I'll see them a little bit earlier. If they're kind of like, 16 or 17, maybe I'll see them every 4 to 6 months. But on average, I see most of my patients every 3 months. So there's an example of a topography of astigmatism. So the picture on the left, it shows you the astigmatism is mostly inside the middle part, the circle part. So that tells me it's apical astigmatism. So fitting a ortho-K on this patient is actually pretty easy. You can actually still fit a spherical ortho-K on there, because when you look at the outside edges, it looks pretty spherical. When you look at the picture on the right-hand side, that's called limbo to limbal astigmatism. That one's harder. So you can't fit a normal, typical spherical ortho K. That lens will be moving left and right, up and down a lot. So those ones you have to really create a toric ortho K lens. And the magic number is 30 micrometers in sag height. So when you're measuring using your topographer, there's a function that can check what's the height elevation difference between the flat meridian and the steep meridian. If it's more than 30 micrometers, usually you'll have to fit them with a lens that has astigmatism in it, or design. So hopefully you guys learned a little bit on that part. Back to Ortho K. I know you guys still, I didn't really dive into Ortho K, but pretty much the whole idea is that you can build this mold and redistribute the cells or through fluid. That way you can make a flatter cornea. If you only make it one meridian flatter and the other one's not flatter, then you can create imbalanced astigmatism. Now, sometimes the lens will move up, sometimes the lens will move down, sometimes left or right. So some of the troubleshooting is sometimes if your maps are not done properly, then you're not going to create a really accurate lens. Sometimes the lens is too moving up or down. Sometimes your lens is too flat or too steep. Sometimes if you get a lot of SPK on the cornea, then maybe the lens is too flat. It's just like rubbing against the cornea. So that's the stuff I think you should be learning in school. You know, the one that we always want is a bullseye design, but sometimes you get something called smiley face, frowny face, or sometimes central islands. You'll learn all those terms in school. That's when they'll tell you how to troubleshoot, and each company will have their own different way of changing it. But at the end of the day, usually it's they'll change the curvatures of those curves, right? So what happens if you have a kid that can't do ortho K, or sometimes their progression is not really going, they're not, you get teenagers like 17 or 18, that's not really progressing a lot. They don't sleep 8 hours. Well, we can go to specialty contact lenses. So for specialty contact lenses, I usually do it under someone that's -1, or if someone that's really high, like -8 or -9, I'll go to special contact lens. Or if the astigmatism is like higher than -350. So those are sometimes criteria that I will start patients on specialty contact lenses. And what is it? So remember, the whole idea is that we want to get rid of the peripheral hyperopic defocus. So we want to focus everything up close. So again, we try to create, most of the lens will be focused in the front. And one way that we can do it is through multifocal contact lenses. See, hold on. Let's double check. Yeah, I didn't talk about that. Okay. So the whole idea is that there could be multifocal zones, one for far away, one for up close. So some of the popular brands that you guys might have heard is MySight from Cooper Vision. Well, first of all, disclosure, I don't get paid by any of the companies, so I can really talk about any product I want to talk about. For MySight, they have two zones like this, and where they have a dual zone, one for distance, one for near, and it shows that with MySight, you can slow it down by 59%. And then there's also one called Natural View. Oh, the great thing about MySight, they're daily contact lenses, so which is great. Another daily lens is called Natural View. It works kind of same idea, but it's with multifocal, but it uses a pinhole effect. So that also can slow it down. So when you're in your clinic rotations, be aware of MySight, be aware of Natural View. There are some, commercial practice where like, hey, the patient, have some trouble affording it. You can also use Cooper Vision, Biofinity multifocals, or you can use ProClear multifocals. And the minimum add you want to use is plus 250 distance minimum. So for the other brands, they haven't really done research on it. So the one that done extensive research is the commercial ones is the Cooper Vision, Biofinity, or the ProClear plus 250 distance. Okay. Now there are new ones coming out too. I think there's one called Abilities coming out. So there's going to be a few more coming out very soon to the market. So specialty glasses. So sometimes out of 20 patients, I'll have one patient that cannot put any, don't only want to touch their eye, like don't want to put an OK lens, don't want to put in soft contact lens, anything that get to their eye, they start to scream. So that's when we do specialty glasses. So I didn't get this technology until last year summer in July. So we're one of the first clinics in BC to get them. So the ones that I use a lot in my office is called the Hoya MyoSmart lens. So the central zone corrects the refractive, and then they have a honeycomb shape that causes myopic defocus. Again, it's always about that whole myopic defocus theory that we want to create. So this lens was developed in Hong Kong, Polytech University, and it's been using in Asia for about 2 or 3 years, and we didn't get it until like last year. So it's working actually pretty well. I'm happy with the lens, but it's sometimes really hard to show patients those honeycombs. You have to look at the light at a different angle in order to see it. So for kids that worry about cosmetic, you can't really see it. And the other questions a lot of parents have is like, will it affect their sports, reading? One thing I found out about kids is that they're so versatile; they can adapt to anything. So maybe out of all the kids, maybe 1 in 10 kids might have a problem with this lens, but usually once explained to them that's normal, they adapt to it. So I haven't had to do any redos or refunds on this lens. There is a new lens coming out, probably called Stellite coming out, and there's another one coming out too. So we're gonna have lots of options for lenses. Oh, and the thing about back with OrthoK, the success rate for OrthoK is between 50 to 80% to slow down the progression. And then for the soft contact lens and these glasses are usually around 60%. Lastly, atropine drops. Doing time 336. So usually we drop it at nighttime, dilates the pupils, paralyzes the muscles, relaxes the muscles. Most optometrists use 0.01, 0.02, 0.05%. At my office, I just use 0.05%. So the question that you probably get asked by your attending is, hey, how does atropine work? The answer is we don't know. We have no idea how it works. All we know is that it just slows it down. So the whole story about the atropine is, well, we have some time, so I can talk a little bit about the atropine. So when it first came out, so studies in China, they use 1%. And, this kids keep going up and up and up. They throw the 1% on. Guess what? It actually slowed down or actually stopped the progression of myopia. And they were like all excited about it. So a lot of doctors back then just use 1%. But, not be able to read, sensitive to bright lights, it wasn't really the ideal choice of drug to use 1%. You guys know how when you guys dial each other practicing, BIO and slit lamp, it's hard. You can't really see anything. So they did a study, the ATOM study, and they tried 1%, 0.5%, and 0.01%. And the 0.01% was the control group. So when they did it, they ran it, they're like, whoa, 1% worked well, 0.5% worked well, and they were surprised that 0.01% worked very well also. So like, what is going on? And the other thing they found out was that the 1% and the 0.5%, once you stop using the medication, there's a big rebound effect. So your prescription would just jump up very high. And they found out that the 0.01% didn't jump up very well. So that leads us to, scientists and optometrists are like, well, what happens if we use low dosage, like 0.01, 0.025, or 0.05? Like, would that work? So what they did was they created the LAMP study, and they tried 0.01, 0.02, and 0.05. And they found out that, hey, it actually, all three of them actually works. And then when the LAMP 2 study came out, they were like, hey, guess what? 0.05% actually works twice as well as 0.01%, and the side effects is very minimal. So this came out last year, December, and we're like all excited about it. So that's why a lot of doctors are just hit it hard and just treat them with 0.05%. And then finally, I think just like a couple of days ago, well, the question you want to ask, you would probably ask is, well, will 0.05% have any big rebound effect? And there's a paper that just kind of talks about the phase 3 part, and they found out that the rebound effect is very similar with 0.01, 0.02, and 0.05. So there wasn't that big of a difference. So having said that, uh, you can feel confident to prescribe 0.05%. Caveats on atropine. Um, Number one, you will get still some sensitive to bright lights and some trouble reading up close. So, and you also have to make sure the patient has to sign a consent form to use atropine because it is off-label use. So if you do start anyone with atropine, they have to sign a consent form that you're using it off-label because if you get like a lawsuit, you'll get in trouble. So make sure you do that. Um, the other question I get a lot with atropine is, well, if I use 0.05%, it's like 5 times the concentration of 0.01. So my side effects will be like 5 times worse. So as I mentioned earlier with the LAMP study, it doesn't show that. The side effects seems very similar. So one of the examples I like to give to my patients or parents is that they used to use 1%. So I use that's like a sugar cube. So imagine there's like one sugar cube. And then 0.01 is 1 grain of sugar. And then 0.05 is 5 grains of sugar. So it's really not going to make that much of a difference. But the studies have shown that it works way better, 2 times the effect of slowing down the progression. So that's atropine. Another side note. See, this is always new technology coming out. So there's a company that's trying to figure out what other molecules can slow down myopia, and there's a company that found out that there's like one other drug that can actually slow down. They didn't have a name for that drug yet, but they call it like some sort of molecule name, and it can actually slow down the progression of myopia. And how they had like about 20, I think it was 12 or 20 molecule or different type of chemicals or molecules, and atropine is actually one of them that can actually slow down the myopia. So there should be newer drugs coming out that can slow down the progression and probably have less side effects. So just, yeah, it keeps changing myopia. That's why it's kind of exciting. Common side effects: dry eye, dry mouth, sensitive to light. You feel nauseous and some dizziness. All right. So that's the end of my presentation. I saw some questions, but I guess Helen will ask me those questions and I will answer them.
Yeah, so thank you, Dr. Tung, for sharing. It was a very nice overview of all the types of myopia management. So the first question we have is the max length, like I'm thinking it's the axial length slide that you had. And this
Yep.
question says the max length for adults is lower than for teenagers. Why is that?
So they took an average of like that was just an average of the axial length. That's what the paper just shows. So remember, they didn't compare different ethnicity. They didn't look at that's just an average prescription. An average axial length. So you have to take it with a grain of salt. So they're gonna come up with new papers to see if there. Hopefully, there'll be some sort of a calculator that will plug in your um, your axial length for your age, ethnicity, and they'll tell you if you're within normal range or not. So for now, that slide, just kind of take it with a grain of salt. If you know someone's outside that range, then just be aware of it. Maybe you want to treat a little bit more aggressive. So if you're starting the patient on atropine, then you might want to add. Oh, my, sorry. If you're on ortho-K, then you might want to add atropine. So again, this is kind of like just a ballpark.
Okay. And the second question is there any age limit for using Ortho-K?
There's no age limit. My oldest patient is like a 40-year-old. So usually your eyeball length will kind of stabilize around, like we said, like 13 to 16. So if you haven't been growing, usually after 18, usually we just tell you, hey, go get laser surgery done, right? Because as you get older, you get busier, you might want to have kids, you might not be sleeping 8 hours a day. The other reason why, as they get older, I don't usually treat them with ortho K is because they don't, sometimes they don't grow the cells, we just show the fluid or growing the cells, they're not as efficient as kids. Like healing and wise, like kids, you put that lens on, they can change the diopter by almost two diopters in one night. With adults, sometimes it takes longer. Sometimes it takes two diopter change, like in 1 week. So if they're -4, -5, something you have to take like 3 weeks to actually correct their prescription, and they get frustrated. So usually, most of the time, once they turn 21 or 22 and their axial length is stable, then I just gotta ask them to go do laser eye surgery then.
All right. Third question. If specialty contact lens control is only 60%, why is it recommended for patients at -8 to -9 diopters? Would Ortho-K work better for these patients since control is 50 to 80%?
So the problem is that with ortho K, you have to make the cornea flatter. So it's kind of like laser eye surgery. So if you have 46 diopters curvature on your cornea and you have 8 diopters, well, you can do the calculation 46 subtract 8, your cornea will be 38 diopters, which is kind of doable. But if your cornea is average like 44 and you want to make it 8 diopters, well, you're all the way down. I can't do math. 44 subtract 8, like 36, or sometimes even higher. Then it's really hard to make the cornea flatter. So that's one reason why we don't do that. Number two, they don't sleep enough, so can't the cell, you can't create a flatter cornea. So that's another reason. And then if they have, sometimes we can't create those cells, create that pattern, then you can't treat them for the high diopters. So hopefully that answered the question.
Okay. Next question. What are some mechanisms of how myopia increases the risk of cataracts?
So I think the idea is that when you kind of stretch, okay, so for the lens inside the eyes, as you guys all know, aware of, it's kind of like an onion, add layers and layers and layers and layers. So it has to be normal growth. So what causes a cataract? So the number one thing that can cause a cataract is UV light. So, you cook that protein, denature it, it'll become white. So that's the easiest one. Second ones are, chemicals. So if you're, take a lot of steroids or whatever, that can also cook the lens. So anything cooking the lens. Third reason why you can get it is probably um, trauma. So you can get a traumatic cataract. So if you get hit in the eye, the lens can start to denature and can get cataract. So the fourth reason is what we think is that when you keep stretching the eyeball back and forth, putting a lot of stress on the lens, and that might be creating a cataract also. But again, we don't know the definitive mechanism of action, but those are some of my theories of why you might have an increased risk of cataracts when your prescription's higher. So hopefully that answered the question.
Yep. Okay, next question. What are your thoughts on vision therapy for myopia management, if there is any?
So one thing I did not talk about is when you have like an ACA ratio, very high one, or you have a lag, a very high lag. You remember you guys do your MEMs. Um, then it's kind of hard to treat them with ortho K because sometimes you'll create you'll create problems with reading, okay, and then they're not gonna have clear binocular vision. So usually when I see some sort of strab or some sort of thing, I want to treat that first before I do um, myopia control. Now we just had a patient the other day where one of the doctors was referred to us, and they had a whole accommodating facility, and they were having accommodative problems, and the NRA PRA were not balanced. And this patient was on atropine, 0.05%. Um, we had to take them off the atropine, treat their underlying problem first. Once it's treated, then we put them back, and then we put them onto Ortho K. Then we put them back onto Ortho K, and they were able to fuse um, and get clear binocular vision. So there are cases where I'll see a patient and I'm like, I can't treat because I know I'll create more problems because I'm taking away their plus. So we had to treat the binocular vision therapy part first, then I do the myopia control part. So that happens maybe for every 20 cases, I'll get one or two of them. So so I'm so glad that we have like a vision therapy here at this office. I'm not a specialist in vision therapy. My associate, Dr. Melody Tong, that's her residency is in pediatric and binocular vision. So that's vision therapy. That's her specialty. So we work together as a team. Hey, what will happen if I did this? So like, well, this is what's going to create. It's like sometimes you ask me, like, he needs more plus, then maybe we'll have to start the specialty lenses. Maybe I have to use +3 that distance. So we have to play around with it, looking at what their uh, binocular statuses and their accommodative and versions and all that stuff.
Okay, so there's like no, it's not like directly, like you can't directly manage myopia with vision therapy, right? Is
There are some people that claim that, but there's not enough scientifically like papers that's peer reviewed, double masked to kind of actually say that. So it's kind of hard to say. Some people say there's a feedback loop that you can slow down the progression, but I don't. There's no one paper or one study that shows that it can slow down with vision therapy only.
okay, cool. Next question. What is the difference in affecting myopia of under-minusing, over-minusing, and using the actual RX?
So a lot of doctors will. Okay, so the worst is undercorrecting them. Okay, so there's a study that shows that if you undercorrect a patient, their myopia will progress the quickest. Second one is over-minusing. But that's why it's always important to do a cycloplegic refraction before you treat any patient with myopia, so you get the true prescription, especially those low myopes, because it can trick you. So there's a few times where the patient's like -100, -125 maybe, they're over accommodating, and then you put the dilation drops in there, and they're like +50. So so try not to under-minus them, but that's not the worst case. But the worst case is undercorrecting. And then finally, you always want to give them the most accurate prescription. Um, but that will be the least amount of increase of progression. But, with all these tool nails, I don't think it's a good idea to even fit them with normal glasses. We have the Hoya, MyoSmart. So I will go with that lens instead.
Okay. Are there any side effects of using Ortho-K long term, for example, for over 20 to 30 years?
Uh, It really depends on how you fit the lenses, okay? So back then when I started treating with Ortho K, it was a set diameter. It was a set optical zone diameter. And when you try to fit one size fit all, you're gonna create some problems. Sometimes you can get SPK, you can get corneal warpage. Yeah, there are side effects for that, okay? But nowadays with all the new lenses, all the ones that you can design, you can control any curve you want, and it actually sits on the eye and molds much quicker, the side effects is actually very low. The only thing that you probably want to be aware of is that if you're planning to do laser eye surgery down the road, you probably want to be off ortho-K for at least a year. Well, depending how long you wore it, but you want to be at least off a year, so then that way you get the most accurate results for your LASIK or PRK. But in terms of long-term side effects, if it's done properly, the side effects are usually very rare.
Okay. Do you see a large benefit to doing a cornea and contact lens residency with regards to offering myopia control for patients, or is it possible for a newly graduated optometrist to self-learn it?
I get that question a lot. Um, if you guys can do a residency, I will highly, highly recommend you do residency. Well, it depends on what your goals are. I did my residency in ocular disease and primary care in Chicago. Yes, I learned a lot about ocular disease, and again, lots of studies always keep changing, but it gives you that foundation on how to look for information, how to study, so you're always gonna be on top of your game. Um, and because I did that residency, I was able to apply it to, contact lens. I was able to how I read my papers, how I was trained, how, you know, the teachers or like your mentors will actually challenge you. When you're a student, most of them will be like, okay, if you're good enough, you pass, okay, fine, you're good, just but once you do residency, their expectations on you is so much higher. It's almost like 4 or 5 times higher. So you kind of have to perform. And and then when they force you to write papers, when they force you to write, reports and stuff like that, and you get grand rounds, you have to be grilled every single week. Why do you do this case? You start thinking in a different way. And that's what residency actually does is prepare you to think critically. And so I didn't do a cornea residency, but looking back when I was doing my fellowship for my FIAOMC, I was so glad I had that training in ocular disease as my residency. If I didn't, I don't know if I would be able to become a fellow. So if you know, if your goals is, you want to be the best and you want to practice more than just refraction, I will highly recommend doing a residency. And most of the time, it's just human nature. You know, we always want to do things. Oh, we'll do it later. We'll do it later. We'll do it later, and then later you won't do it. So a lot of my colleagues like, oh, I want to do myopia control, and they learn a little bit. It's like, oh, it's too hard. Like, oh, there's too much work, um, because they don't have the discipline or the background to actually. Well, I don't understand this part. Then they kind of stop. So I'm saying that in the future, there's going to be more different technologies could keep changing all the time. And if you do a residency, I believe that it prepares you, the mindset to specialize in anything you want. So if you do a residency in vision therapy, low vision, um, ocular disease, contact lens, I think it's very helpful.
Okay, sounds good. Um, Next question. Sorry if you already mentioned this, but what is the efficacy rate for atropine?
Atropine's about 50%.
Okay, and then to clarify, you said that over minusing a low myop would still cause myopia progression.
Because we were talked about the peripheral defocus, all that stuff. So sometimes it really messes the patient's accommodating system. So we don't know how that affects the peripheral defocus. So the worst is undercorrecting. The second is overcorrecting, and then the last one is to correct the prescription. So that's just in order.
Okay, and then next question. What are are there any long-term side effects of atropine, like after you stop using it?
So they're still studying it, but if, as mentioned earlier, if you use the high concentration, there could be a rebound effect. Um, so that your prescription can just jump up after you stop using it. But in terms of the studies with low concentration, you get those side effects, sensitive to bright lights, but over long term, I mean, the study just came out. I think it's like past 6 years. So within this past 6 years, there's usually no side effects after that.
Okay, I think that's all the questions that we have. If you have any, if anyone has any more last minute questions, you guys can send it to the chat. If not, we can do the poll. And I think for me to do the poll, you have to, like Dr. Tung, you have to give me back the presenter.
Hold on 1 second. How do I do that?
So you go to participants and then you right click my name. And
I just press escape. I think it might work. Wait, hold on. There you go.
okay, let's see for the poll. Okay, yeah, I can do it now. Okay, so let me add the question. Okay, I think you guys should be able to see the poll now. So there's one more question, and it says, you said that the efficacy of specialty contact lenses is 60%. How about specialty glasses?
About 60%.
So the same
59,
thing?
60. Yeah.
Okay. Okay, a few more seconds for the poll. And if you have any more last minute questions, you can also send it to the chat. Okay. Okay, so thank you, Dr. Tung, for presenting tonight. I hope everyone learned a lot. Wait, there's one more question. What is the approximate cost of all the options?
So we're not allowed to talk about pricing. Each clinic will be a little bit different. So ortho-K lenses usually ranges around $500 to $800, depending on which brand you're using. And then for my site, they usually range about close to $600 to $800 for a year supply. The Myo Smart glasses usually is around 500 to 800. What else is there? So majority of all the products are between $500 to $800 a year. In terms of service, it depends on what you want to do. Sometimes a lot of people will, you know, um, do a global package. Sometimes they will do it per visit. Um, it's hard for BC. We can't build MSP. You can't like refraction. You can't do that. So you have to kind of educate to your patients, the value of your service and why you're doing it. So some people do yearly, some people do per visit. It really depends on what mode of practice you're doing it in and calculating your chair time. So if your chair time to break even is $100, well, you probably want to charge more than $100 per visit. So you guys will have to do your math for that. But some people range $1,000 sometimes for a year, or sometimes some people do a global for until they're 16 or 15, and maybe that'll be like $2,000. So each one is different. So it really depends on how many visits per patient, how many times the patient visits you per year.
Okay, sounds good. So thank you everyone for joining us tonight. I hope you guys learned a lot, and I hope you guys continue to have a great reading week. Bye.